A woman in Ohio refused to open her refrigerator for 3 years. Not because of the food, because of the color yellow. That is a real, diagnosed phobia. And it is nowhere near the strangest one on this list. Most people assume phobias cluster around the obvious: heights, spiders, the dark. But clinical records tell a completely different story. Take somnophobia, the fear of falling asleep. Not nightmares. Not what happens during sleep. The act of closing your eyes and losing consciousness. People who have this describe the moment right before sleep as a kind of controlled death. They fight it for days. Some have gone 72 hours without rest just to avoid that threshold. Doctors who treat it say the hardest part is that every single night, the fear comes back. There is no avoiding the trigger. You cannot cross the street to get away from sleep. Then there is isoptrophobia, the fear of mirrors. Not because of what might appear in them, because of what looking at your own face actually feels like. Patients describe a creeping wrongness, a sense that the reflection is slightly delayed, or that the face staring back has intentions the person standing there does not. Some cover every reflective surface in their home. One documented case involved a man who navigated his entire apartment by feel for 11 months rather than pass a bathroom mirror. And then there is xanthophobia, the fear of the color yellow. That is the woman from Ohio. Yellow is everywhere: traffic signs, food packaging, sunlight filtered through curtains. Managing xanthophobia means managing the entire visual field of a normal day. Researchers who study color-based phobias note that sufferers frequently develop secondary anxiety around going outside in summer, when flowers and signage make yellow inescapable. What connects these three is the mechanism. The brain has flagged something completely neutral, sleep, a reflection, a color, and reclassified it as a mortal threat. The amygdala does not distinguish between a tiger and a yellow coffee mug. It just fires. And once it fires consistently at the same trigger, the phobia is structurally real, regardless of how it looks from the outside. This is not weakness. This is a misfiled threat response that the conscious brain cannot override simply by knowing better. Knowing a mirror is safe does not stop the spike of cortisol. That gap between knowing and feeling is exactly where these phobias live. Some phobias do not attach to objects at all. They attach to ideas, and that makes them almost impossible to escape. Chronophobia is the fear of time passing. Not of dying, exactly. Of the movement itself. The second hand on a clock. The way a birthday confirms that another year is gone. People with severe chronophobia report that the new year is among the most destabilizing events on the calendar. Midnight is not a celebration, it is evidence. Therapists working with chronophobia patients describe sessions where simply mentioning a calendar day triggers a full panic response. Closely related is atylophobia, the fear of imperfection. This one gets misread constantly as perfectionism or high standards, and that misreading causes real damage. Perfectionism is a drive to do better. Atylophobia is terror at the possibility of failing to be flawless. The distinction matters because atylophobia does not motivate, it paralyzes. A person with atylophobia may not submit a work project for months because submitting it means it can be judged. Leaving it unfinished keeps it theoretically perfect. The incompleteness becomes a shelter. Then there is decidophobia, fear of making decisions. Any decision. Not just major life choices, but which route to take, what to order at a restaurant, whether to reply to a message. The person with decidophobia understands that a choice must be made. They simply cannot bear the weight of having made it. Because every decision carries the possibility of being wrong, and being wrong confirms something terrible about the self. Researchers note that decidophobia and atylophobia frequently appear together, and together they can reduce a person's functional independence to near zero. The pattern here is that all three phobias are about something that cannot be physically avoided. You cannot leave the room to get away from time. You cannot refuse to ever make a choice. The trigger is baked into being alive. That is what makes concept-based phobias particularly resistant to standard exposure therapy. There is no manageable, gradual exposure to the passage of time. When people hear certain phobia names for the first time, they laugh. Then they read the case files. Arachibutyrophobia, the fear of peanut butter sticking to the roof of the mouth. The name is almost deliberately ridiculous. But the actual experience is a choking-based panic response rooted in the fear of suffocation. People with this phobia do not intellectually believe peanut butter will kill them. Their throat does. The sensation of that thick adhesion triggers the same neurological cascade as actual airway blockage. Food anxiety disorders and this phobia frequently co-occur, and the social consequences are significant. Meals, children's parties, lunchrooms become navigational hazards. Hippopotomonstrosesquipedaliophobia is, and this is real, the fear of long words. The irony is deliberate. The name was constructed that way. But the phobia itself is genuine and generally connects to reading anxiety, fear of public speaking, and a learned association between long words and the humiliation of mispronouncing them aloud. Adults with this phobia frequently avoid professional contexts where technical vocabulary is expected. And then there is nomophobia, no mobile phone phobia. Fear of being without your phone. This one is new enough that it sits in a gray zone between clinical phobia and culturally normal anxiety. But researchers studying behavioral addiction argue the line is already being crossed. When separation from a device triggers elevated heart rate, tunnel vision, and an inability to concentrate on anything else, that is not preference. That is dependency with a fear architecture underneath it. Nomophobia is worth pausing on because it may be the first mass-scale phobia that a technology company accidentally engineered. The variable reward structure of notifications, the same mechanism slot machines use, appears to be capable of producing genuine phobic attachment in a measurable percentage of users. That is a new kind of phobia. And it is almost certainly not the last one technology will create. Here is a number that tends to surprise people. Roughly 1 in 10 adults meets the clinical criteria for at least one specific phobia. 1 in 10. That is not counting social anxiety or generalized anxiety disorder, just specific, diagnosable phobias. The real number is almost certainly higher because most people never mention it. The reason most phobias go undiagnosed is avoidance. If you are afraid of clowns, you just do not go to circuses. Life accommodates that easily. But when the fear is of something unavoidable, a color, sleep, time, your phone, avoidance starts to reshape your entire life, and you reshape it so gradually that the cause and the effect become invisible even to you. Clinical psychologists identify 3 major origins. Traumatic conditioning. A single frightening experience creates an association that the brain generalizes. A child who chokes slightly on peanut butter and panics may encode that as a permanent threat. Vicarious learning. Watching someone else react with terror to something teaches the brain to preload that fear without any direct experience. Informational transmission. Being told repeatedly that something is dangerous, even in a joking context, can wire a threat response. Phobias, unlike most mental health conditions, can be linguistically installed. The treatment picture has improved substantially. Cognitive behavioral therapy combined with graduated exposure remains the most effective approach. For concept-based phobias, newer models using acceptance and commitment therapy, working with the fear rather than fighting it, show strong results. Some phobias resolve in as few as 5 structured sessions. But the most significant barrier to treatment is still the oldest one: the belief that a phobia is an embarrassing quirk rather than a neurological misfiring that can be corrected. The woman afraid of yellow did eventually get treatment. It took her 3 years to ask for help because she was certain no one would take her seriously. That delay is the real cost of how we talk about this. And it is the part that